Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, everyone, and welcome to this edition of Doc Talk with Monument Health. My name is Mark Houston, and when we think about cancer prevention, there's lots of routine screenings that we know of, mammograms, colonoscopies, these things that can help catch cancer early. But what if we could go a step further? What if we could understand our cancer risk before it even begins? That's where cancer genetic testing comes in. And today, I'm joined by Jennifer Knowles, who is a board-certified family nurse practitioner at the all-new, you just told me, really, Cancer Genetics and Prevention Clinic at Monument Health and the Cancer Care Institute. And you specialize in helping patients navigate the world of genetic testing, I guess is what we'll talk about today. So thanks for coming in and doing this, Jennifer. This is awesome. I'm really excited to talk about this.
Thanks for having me.
You bet. So this is, like you said, a brand new thing at Monument, really. How did it all come about, and how did you come to lead it, for lack of a better word? Because it's just you there, right? I mean, for right now.
Yes, it is just me. So we had a gynecological oncologist working at Monument that had done a lot of genetic testing in her fellowship. And so it was kind of her dream to start a genetics program at Monument Health. So that's kind of how that position got created. And so, but me, I just applied for it and I got it. So
oh, even better. You didn't have to do any of the groundwork. You're like, no, I'm just going to run it. Thanks for getting it set up for me. Is this, I mean, genetic testing isn't like new in medicine, but is it for what you guys are laying out there at the Cancer Care Institute? Is it something new-ish?
So this is something new that we offer locally. Mm-hmm. So we were doing genetic testing before this program, but people generally were referred outside to Sioux Falls usually. So they would generally talk to somebody on the phone that would do the genetic counseling part of it.
Well, and you're local. You were born and raised here in Rapid City, and then you went off to Columbia. You said you had kind of a weird route to get to where you are today. Did you know, though, when you were in school, in high school or whatever, that you wanted to be in the medical field? Was that the path you were on?
Yeah, there was two paths. One of them was music. I come from a musical family,
really?
And both my parents are music teachers, and everybody in my family plays musical instruments. So it was either that, and then my other interest was healthcare. Mm-hmm. So. But I ended up choosing healthcare, and so I kind of wandered a little bit, and then I found a good program at Columbia. So. And
you said you started here or finished with the School of Mines?
I started with School of Mines. So I graduated Central High School, and then I had a bachelor's degree at School of Mines, and then I went to Columbia. And then ended up here. Back home, right?
Where it's, I'm assuming, a little less stressful than being anywhere in New York, right?
Probably. I left New York, but no, I'm happy to be here.
It's a great place to visit, but raising a family, obviously, I think it's just a little easier out here for
Definitely,
sure.
Yeah.
Well, like I said, I mentioned when we started here, we all hear about routine cancer screenings, the stuff we're supposed to get. For guys, get your colonoscopies. For women, get your mammograms, things like that. But this genetic testing is now taking things to kind of a whole new level, isn't it? Can you kind of break down exactly what cancer genetic testing is?
So cancer genetic testing, that it's a DNA-based test that we do. So we're essentially looking at someone's DNA. We're looking at certain genes to see if there's any mutations or alterations in their genes that may increase their risk to develop certain cancers.
Okay. And a lot of people we've heard the term genetics forever too, but it just seems like still a mysterious thing that's out there, right? What does testing actually look for when you're identifying these mutations?
So it essentially looks for anything different than the genetic code that is the standard genetic code. So we've mapped out the human genome. They had the Human Genome Project. And so anything that is different from that standard code is called a variant. And some of them are what we call harmless variants, and they don't really have any effect. Some of them are harmful, and they change the way the gene functions. And so those are the kind that can increase risk for cancers.
Can you tell that right away when you're looking at it? When you're looking at that strand of DNA, can you look and be like, "Yep, that's harmful"? I mean, that's you know right away because you have enough of those. I don't know that you've seen that you can tell immediately when you see something like that.
And that's getting into kind of the technical part of the stuff that I don't do.
Okay.
So those would be like the geneticists and stuff. But I think that they, what they do, their process is and sometimes we have changes that we find and we're not sure what the outcome will be, whether or not it will change the gene function, and we call those uncertain results. And so essentially they have to gather enough evidence in order to call it a harmful change.
Oh, it's still so fascinating though that we have the ability to do this now. You know, and like we talked a little bit before the podcast started, is it's almost you want to know, right? If you have a history of it in your family, obviously. But then if that history is there, you probably think, well, okay, I'm going to get it. But just the ability to test for this, it's kind of scary, but good to. I mean, does that make sense?
Yes.
Do you get that from people that say that same thing?
I do, and I'll tell you that one of the reasons why I became interested in this is because I went through the process myself. So I went to my primary care provider a couple years ago, and I said, my grandfather died from colon cancer at age 49, and my mom had colon cancer in her 60s. When do I need to start getting a colonoscopy? And she said, now. And I said, oh, okay. And I was in my 30s.
Right.
So I went and had my colonoscopy, and they ended up finding polyps and one really large polyp. So it was a 3-centimeter polyp, and it was tucked up in my hepatic flexure, and that's the kind of the curve of the colon that goes around the liver. And she said, I can't remove this, so you're going to need surgery. And so I kind of prepared myself for that. And then a few days later, she called me and said, I've been thinking about you, and I want to send you to Mayo Clinic to have them try to remove it endoscopically, so with a procedure called endoscopic mucosal resection. Mm-hmm. So this was to avoid surgery. And so she said, also, I want you to have genetic testing for Lynch syndrome. So that was scary.
Well, I'm sure it would be.
And so I essentially, of course, you get on Google and you're like,
right. You're just scaring yourself more at that point, maybe a little.
And so, it is very scary. Mm-hmm. And so I went to Mayo Clinic. They were able to remove the polyp, and now, I get a lot of colonoscopies.
Right.
I went through the genetic counseling and the genetic testing. So I went through the whole process. I went through the scared process, the anxiety. But what I came to the conclusion was I kind of had a sense of control. And then it was empowerment. And I said, okay, this is actually going to help me do what I need to do to stay healthy. And so I ended up not having Lynch syndrome.
Good.
But I still really understand kind of what my patients are going through. And so it definitely is kind of a spectrum of emotions.
Yeah.
I think most people do kind of come to that point where they find it empowering.
Well, and it's got to be, just like you said, so almost a relief to know that, the person I'm talking to has been through this. And they know exactly what I'm going through, right? Mm-hmm. I don't think you get that from a lot of doctors or specialists in a lot of instances. So that just has to be a giant relief. Yeah. Really quick, what is Lynch syndrome?
So Lynch syndrome is actually a kind of a common hereditary cancer syndrome.
Okay.
It's about 1 in every 270 people have Lynch syndrome. And it increases risk for a whole bunch of cancers, but primarily colon cancer and uterine cancer.
All right. And that's something this can screen for that.
Yes.
Okay. Well, speaking of that, if someone is considering a genetic test, then what should they expect?
There's all kinds of ways to get genetic testing. Sometimes it's done through primary care offices. Sometimes GYN offices will do it, breast surgery. But traditional way would be to go see a genetic counselor or a other provider that's been trained in something called cancer genetic risk assessment.
Okay.
And so that's the training that I've had. So I'm not a genetic counselor, but I did have take extra training to be what's called a genetic cancer risk assessment provider.
Okay.
Yeah, it's kind of a mouthful.
Just the long names, yeah.
Right. So essentially you would meet for a pre-test counseling session where you would go over your history and your family history and then essentially talk about the testing and all the benefits of it and also some of the limitations of it.
Right.
And there's some risks like anxiety, depression, things like that.
Yeah.
So, but the actual test itself is really easy. Usually it's done by a blood draw. So similar to just having a blood count done at your primary care's office. If somebody if they have a needle phobia or something like that, then we can do other options like saliva sample, or you can do what's called a buccal swab, which is just scraping the inside of the cheek to gather cells that way.
So it's a pretty easy way to get it done then, really.
Yeah, so pretty simple.
Well, one of the big questions that'll pop up now that we've kind of explained how this works is insurance coverage and money and how this is paid for, right?
Number one question I get.
So how accessible is it then in terms of cost? And does insurance cover it?
In general, most of the time it does.
Oh, that's good. And that's good news.
Historically, genetic testing has been very expensive and not well covered by insurance. But we've made some great technological advances that has really brought down the price, and it's much more accessible now. When we talk about insurance coverage, we kind of talk about most of the time with insurance, it's about medical necessity and whether or not it's going to be covered. But there are national guidelines put out by the National Comprehensive Cancer Network, and so that's a group of leading cancer research hospitals has a panel, and they kind of come up with guidelines of who would benefit the most from genetic testing. But that doesn't mean that not everybody would benefit. So,
it seems like everybody would benefit.
Yeah. So even if you don't meet those guidelines and insurance doesn't cover it, you would still benefit from it, and it's still pretty accessible. Because if it's not covered by insurance, most lab companies will give you an out-of-pocket option for about $249.
Well, that's not terrible. I mean, for peace of mind at least, or I don't know, like you said, being able to empower yourself with the way to fix it or to move forward. That's not too bad.
Yeah.
Well, who is this kind of genetic test? Is it really for people who have that strong family cancer connection, I guess, for lack of a better term, or who really should do this kind of test, Jennifer?
Yeah, so I have a very low threshold for offering testing because I think that anybody can do it. And honestly, it's beneficial to anybody that kind of just wants to know their risk and be proactive about their health and cancer screenings. There are some things that would make us, more suspicious of a hereditary cancer syndrome. And those are people that have a strong family history of cancer. Another thing that we kind of look at is if you've had people diagnosed in your family with cancer at a younger than expected age. So, for example, breast cancer, unfortunately, is common, but we typically see it in later ages, late 60s, 70s, 80s.
Right.
If we see somebody diagnosed at age 45 with breast cancer, we're a little more likely to suspect that there may be a hereditary cancer syndrome. Anybody with a certain number of cancers, like multiple breast cancers in a family or multiple generations with breast cancer. And this is for kind of all cancers, not just breast cancer.
Right.
So multiple generations of colon cancer or other things. The other thing would be rare cancers, like male breast cancer, things like that. So there's definitely things that we look for.
Yeah.
Okay.
You mentioned this a little bit when you were talking about genetic counselors, which you said you're not a genetic counselor. But I'm glad you touched on that, because that is, like we mentioned a little bit, if somebody comes into you and sits down and says, I'd like to do this screening, but I'm afraid that I'm going to find out that I have a strong cancer risk, right? So where do they go then if they need to talk to somebody like that before they want to do this? You said that's not you, or it kind of is you.
Well, that's pretty much my role.
Okay, all right.
So yeah, I mean, I definitely do all the pre-test counseling, and I've kind of been, and so a lot of the times people do come to me and they say, I don't know if I want to do this. I don't know if I want to know what's going to happen if it's positive.
Right.
So really, we just go through all those scenarios, and it's not. What happens when it's positive entirely depends on the gene.
Yeah.
Because some genes are higher risk than other genes. And so we might recommend more extreme prevention strategies.
Well, and you're putting a plan together with them, though. I mean, that's kind of the point of this, too, is looking at the DNA, saying, oh, you might, okay, here it is. But now here's what you have to do, right?
Yeah, so that would be part of the post-test counseling. So when the results come back, especially if it's a positive result, I always meet with the people, and we kind of put a plan together. And depending on what kind of cancer risks are associated with that mutation, we will essentially, what I do is I'll send them to specialists to help them get screened or talk about preventative medications that might be an option, or sometimes with really high cancer risks, we'll recommend prophylactic surgeries and things like that. So my job is to get them where they need to go to get all those things done.
Well, that's it has to be saving lives. I mean, this whole thing that started here now in Rapid City, if people are doing it, because you said you've got a lot of people that you're pretty booked right now too for people that want to do this. I mean, it has to be doing something, right? I mean, it has to be making a difference.
Well, I think so.
Yeah, totally.
Yeah, I mean, especially when we, test people. And when I think about it, it's not just the people that we're testing. We're also affecting their family members as well. So, if we find somebody with a hereditary cancer syndrome, the whole family, it's kind of a family affair, I say. And so, we get usually another part of the post-test counseling is about something called cascade testing. And that is essentially testing other at-risk family members.
Okay. What age should you do this? Any age can come in and have this done, or what do you recommend age-wise?
We usually wouldn't test for this type of thing unless younger than 18.
Okay.
Unless there was a known mutation in the family that was associated with pediatric cancer risk.
I see.
So generally it's 18 and older.
Okay.
And my kind of general recommendation I give people is to to when it would potentially change management. So, like for breast cancer risk, we usually don't start any sort of, even for high-risk genes, we usually wouldn't start until age 25.
Okay.
So
that gives you a little bit of a guideline there then.
Some people want to know sooner.
I'm sure,
and we
yeah.
do. Yeah. So, but
I'm sure you also get people that come in and are super eager to be like, yes, I want this done. I want to know. Let's go. Right.
Yeah.
Compared to the ones that are maybe. Well, I think one other big question this leads to is once we start getting this ability to test in advance for probably not just cancers, but other diseases. I'm assuming we'll be able to do this at some point as well. Maybe we already can. Is going to be the privacy with this. In your medical data. Mm-hmm. So let's say, yes, you are screened, you do have a high risk for cancer. Then what happens there? Can your employer look at that to deny you health insurance? These will be big questions I'm sure you get as well. How do you navigate that?
And that's definitely part of the pre-test counseling that we do. And so this is something that everybody should be aware of when they do genetic testing. And that is something called genetic discrimination. And so, but we have a law in place called the Genetic Information Non-Discrimination Act.
Okay.
And that is a law that protects health insurance from using any genetic information to deny you coverage or potentially charge you higher premiums.
Yeah, that'd be a big one that people would be worried about.
And that protects against employers firing you or not giving you a promotion based on genetic information. So there's protections in place. And as far as this type of testing that we do, it's medical grade testing. So your genetic information is also protected by HIPAA, which is the
standard.
The standard. Yeah. It's same as all of your medical information.
Right.
So the same type of laws. So there's protections in place. And I think a lot of the privacy concerns comes from more direct-to-consumer testing that's been around, like 23andMe and Ancestry.com.
Right.
So there was, kind of in the media quite a bit of stuff about privacy issues.
Yep.
And so those are private companies that, my advice to people about that is just make sure that you read their privacy laws and things like that. But this type of testing is definitely different. It's medical grade. It's the same as any other medical test that you have done.
Well, that's reassuring too, for sure. Well, as this is, like you said, it's kind of a relatively new-ish field. It's new for Rapid City for sure, and what you're doing. Mm-hmm. What do you see in the future for this? 5 to 10 years down the road? Will there ever be a point where we'll be able to look at the DNA, look at the risk, here's the cancer you might get, and then here's what we do to stop it right now? Do you think that'll ever be something we'll be able to do?
Yeah.
Oh, no,
I think
that's
so.
exciting.
Yeah. Yes, and I think the point of the test is it's not to diagnose cancer, it's not to treat the type of this test, not to treat cancer. It's really a predictive test. So and right now this is like studying what we call monogenic risk. But something really exciting that's happening right now is that they're doing something called genome-wide association studies. So they are studying large groups of people in the population and finding out what sort of genetic changes they have in common and what association that has with breast cancer. So once they figure out a certain group of genetic changes that are shared by people that have breast cancer, we know that those are potentially risks for breast cancer. So that's called polygenic risk factors. So multiple genes contributing to cancer risk. So I think that we're just going to get more and more accurate with our risk prediction. Mm-hmm. And so genetic testing is probably just going to be part of your normal health screenings, and your cancer screenings and other health screenings are just going to be tailored to your personal risk. And so I think it's really exciting.
That is exciting, because if you can just go in and have your blood drawn and have everything from your cholesterol to cancer screening checked at that point, I mean, that's, what a relief, honestly. I understand, and we've talked a little bit about people being apprehensive, wanting to know this sort of thing. But, you hit the nail on the head when you say that it's empowering. Once you know and having that information, then you get to do something about it instead of being like, well, that's it. What can happen now?
Right.
So where do we start with this then, Jennifer? Do you go to your primary care doctor and ask them to if you want this procedure to get started? Is that the best place to start?
There's a couple different things you can do. I work at Cancer Care Institute, and I do accept self-referrals. So people can call and say, I want an appointment for genetic testing. Or you can go through your primary care or any other provider, your GYN provider, just they can send a referral to me. There's another option for people that are kind of on the fence. We have a survey on our website. If you go to the Monument Health website under the Cancer Genetics and Prevention Clinic, there's a self-assessment survey. So it's just a 3-minute quick survey that you take, asks you some quick questions about your history and your family history, and then it will essentially let you know if you qualify for genetic testing.
Oh, that's the best place to start right there. Anything you can do online at night in front of the TV,
exactly.
That's the way to go.
Yeah, it's really quick. And then I also have to stress that even if you don't necessarily qualify for genetic testing, anybody can have it done.
That's good to know, too,
yeah.
For sure. Jennifer Knowles, board-certified family nurse practitioner at the Cancer Genetics and Prevention Clinic at Monument Health Cancer Care Institute. Thank you for coming in and doing this, Jennifer. This was awesome.
Thank you.
And as this stuff advances and as we get to learn more things and hopefully more exciting things down the road, let's come back and talk about it again, because anytime when we speak of cancer and people can hear a podcast that gives them hope, that's what we want to do, for sure.
Definitely.
So thank you for coming in and talking. I appreciate it.
Thank you.